Good morning. And thanks to everyone for joining us today. My name is Dr. Luke Evnen. I am the chairman of the board at the Scleroderma Research Foundation, and I'm also a scleroderma patient. I'm delighted to welcome you to our 13th live webinar, and I'd like to alert all of you that the entire series, as well as a variety of other patient-directed materials and research-related news, are all available at no cost on our website, which you can get to at sclerodermaresearch, all one word, .org. Please do keep in mind that the SRF depends exclusively on your support to speed progress towards a cure. So, to help us find better treatments and to get us to that cure, please consider making a donation after the session today. Our webinar series is made possible by grants from Gilead Sciences, MedImmune, and United Therapeutics. Today's session will feature a 40-minute lecture on scleroderma complications in the gastrointestinal tract, which we'll abbreviate GI tract. We'll then wrap up with about a 15-minute Q&A session, which I will moderate. As in the past, the cell phones are all muted for now, so please, if you do have a question, use the chat box, which is a text format, in the conference window. I also would like to remind all of our participants today that the webinars are really exclusively for general information, and information that we provide is not to be considered personalized medical advice. Scleroderma affects everyone differently. No two cases are alike. It's now my pleasure to introduce a special guest. Dr. J. Pasricha is the director of the Center for Neurogastroenterology at the Johns Hopkins University School of Medicine. Prior to his current role, he was the chief of gastroenterology at Stanford University. He is an expert in neurogastroenterology and deals with disorders affecting the nerves and muscles of the stomach, which cause problems in the GI tract, particularly with respect to motility and pain. He provides his expertise to the patients at the Johns Hopkins Scleroderma Center, as well as patients with motility disorders and diseases ranging from Parkinson's to autism and diabetes to obesity. All those patients stand to benefit from this research. Over the course of his eclectic career, Jay has been credited with more than 30 patents for a range of novel GI diagnostic and treatment-related methods. His extensive publications on the enteric nervous system, which is the nervous system of the GI tract, and the gut-brain axis have garnered global attention. It's my pleasure to introduce Dr. Pasricha to all of you today. The title is GI Complications and Treatments in Scleroderma.
Again, I want to thank Luke for his kind introduction. I also want to thank Amy and others at the Foundation for giving me this opportunity to present on a topic that has been a passion of mine for the last 25 years. And this is, as Luke said, related to the field of neurogastroenterology. What I will talk about specifically today is how the nerves and muscle and other parts of the gut are affected in this disease that we call scleroderma. What I'd like to start with, however, for those of you who are not very familiar with this part of the body, is an overview of gastrointestinal physiology, particularly as it relates to the nervous control. Then we'll talk about some of the most important GI manifestations of scleroderma and some highlights of treatment approaches. In the time that I have, it's not possible to go into great depth of each treatment or each disorder, but I hope to have enough time at the end to answer some more specific questions. And finally, I'll end with really what the future should be about by highlighting some unanswered questions in this field and what potential directions we can take to address these questions. So let's begin with a general approach how the gut is organized. We think about the gut really in terms of the tubes, which we call the luminal organs, those that have a lumen or a hollow center, and the solid organs, the liver and the pancreas. Today we'll be talking predominantly about the luminal organs, or the tubes of the GI tract. An important question to begin with is what controls the gut. Now, as I've shown here in this slide, the gut is under the control of at least two major nervous systems. At the top and at the bottom, as you would want, control is exercised by the central nervous system. This is important because when you swallow, you want to make sure that food or water doesn't go down into your airways, and the CNS, or the central nervous system, has to be firmly in charge. Similarly, at the bottom, because of the social implications of evacuation, we need to be fully in control, and that's where the central nervous system really comes in. But for everything else in between, it's really not the central nervous system. It's not the brain inside our heads, but it's this other brain inside the gut itself that is in control. And this brain is a standalone, autonomous nervous system, which we call the enteric nervous system. It comes as a surprise to many people to know that the gut contains its own nerves, but that's not only true, but here's another remarkable fact: it has more nerves than the entire spinal cord. So together, these nerves are responsible for all the complex functions of the gut that include both secretion and muscular contraction. Where are these nerves located? As I'm showing here in this slide, if you take a section of the gut and look at it under the microscope, you will see that the lining is here next to the lumen, but the gut itself is organized in a series of concentric layers. So here's one of the muscle layers, here's another muscle layer, and sandwiched in between these two muscle layers is one set of nerves, which we call the myenteric plexus, and this controls muscle contraction. And there is another set of nerves not shown here, but that exists right beneath the lining, and that is called the submucous plexus, and that controls secretion by the lining cells. So this is another view of the nervous system and the muscle. If you peel away the layers, you can see the myenteric plexus, which is one set of nerves that constitutes the enteric nervous system, and here's another set of nerves, the submucous plexus. Now, these nerves are actually very sophisticated, and they just don't simply turn on or off, but they actually have the capability of coming up with all the complex programs that the gut needs. And some examples of these programs are shown here. We have the FED programs, which are the programs that are initiated when you start eating. So depending on which organ we're talking about, the esophagus has its own program for allowing rapid transfer of food to the stomach. The stomach has this program for storage of food and grinding it, and then pushing it into the small bowel, where it is mixed with enzymes and absorbed slowly, and then the large bowel, where water is absorbed, stool is formed, and then it's finally transferred outside. There are also programs in between meals, which are also quite important to keep the gut clean and sweep away the debris, and these are fasting programs. So we can see there is a very sophisticated range of movements and secretions that the gut is responsible for, and this is all under the control of the enteric nervous system. Now, unlike the skeletal muscle, where there's really only one type of nerve, in the gut we have several different types of nerves, but broadly we can look at this as falling into one of two categories: those that are excitatory and responsible for contraction of the muscle, and those that are inhibitory, responsible for relaxation of the muscle. Now, both these functions are very important for effective gut motility or movement to take place. And loss of either one of these nerves, not just the contraction causing nerves, but even the relaxation causing nerves, can result in serious disturbances in gastrointestinal function. Now, in addition to nerves and muscle, there is a third type of cell, which is the interstitial cell of Cajal, the ICC, which is also increasingly being recognized as playing a very important role in the movement of the gut. And this cell actually sets the rhythm by which the gut contracts, and hence these cells are called pacemaker cells. So really, what I have said so far is that the enteric nervous system controls many functions in the gut, from secretion to blood flow to contraction in the form of peristaltic reflex. We haven't had time to go into all the neurotransmitters, but serotonin, which you probably heard about in connection with the brain, is a very important neurotransmitter in the gut as well. In fact, 90% of the body's serotonin is in the gut and not in the brain. So I look at the gut as producing beautiful music, and if you break that music down, you can think about the muscle as the piano or the organ, the interstitial cell, which is the pacemaker cell, as the metronome, the myenteric plexus, which is that collection of nerves, as the pianist, and together, like I said, we make the beautiful music that a healthy gut should be doing. So what I've presented to you is the picture of an enteric nervous system that works in just as complicated and as sophisticated a manner as the central nervous system, and hence I often use this cartoon to remind everybody that what we're really talking about is a mini but equally complicated version of the central nervous system. And with that as background, I want to talk about how some of these processes and structures can get affected in scleroderma. Just to begin with, a brief overview of the clinical problem. As many of you might know, of all the internal organs, the GI tract is the one that is most frequently affected. And within the GI tract, the organs that are most commonly involved are the esophagus, anorectum, and small bowel. But actually, many patients present with disturbances of all the organs, including the stomach and large bowel. In some patients, we know systemic sclerosis or scleroderma can present initially with GI symptoms alone, and that can often be confusing if the patient presents to the gastroenterologist, who may or may not be completely aware of all the other manifestations of scleroderma. At the same time, I don't want to give you the picture that everybody with scleroderma has clinically serious GI illness, and indeed many patients, perhaps up to 50% of patients, can be asymptomatic. Of course, these are not the patients who come to see us at Hopkins, but nevertheless, if you do population surveys, a significant number of patients can be asymptomatic. Nevertheless, when the GI tract is involved, it has some serious implications. For instance, particularly patients who have severe GI involvement, which maybe affects 10% or less of patients, their survival can be affected over the next 8 to 10 years, some studies showing only a 50% survival. In many others, even though survival may not be affected, there is significant impairment of the quality of life, and indeed, GI symptoms have been shown to contribute to mental health issues, particularly to depression, both in scleroderma as well as in some other conditions. Let's now do a quick survey of the major clinical manifestations organ by organ. We'll start with the esophagus. The esophagus is the most commonly affected organ in scleroderma, and some involvement is seen in up to 90% of patients. The most obvious manifestations are difficulty in swallowing, which we call dysphagia, and this is due to abnormal motility or the ability of the esophagus to move food down to the stomach. In addition, of course, the problem that has received the most press is acid reflux, which results in heartburn and regurgitation of stomach contents into the esophagus and sometimes into the mouth. Now, apart from the symptoms that these problems can cause, they also have some other consequences. For instance, if acid reflux results in inflammation and this is not treated, then this can lead to a stricture or scar formation, or in some patients it can cause a change in the lining of the esophagus to what we call Barrett's esophagus, which may have some precancerous risk associated with it. Perhaps the most important consequence, which has not been as well studied, and I'll talk a little bit about it later, is the effect of esophageal disease on lung problems. Now here's a cartoon that shows what happens in gastroesophageal reflux in a graphic way. So on top here is a normal stomach. Perhaps the most critical barrier preventing reflux is the lower esophageal sphincter, which along with the diaphragm acts like a one-way valve, allowing food to go down into the stomach but preventing acid from coming back up, as shown here. What happens in reflux is that the sphincter is incompetent, or the diaphragm opening is enlarged, and this barrier is no longer effective in preventing acid from coming back into the esophagus. Here is a cartoon that I want to illustrate in perhaps a little more detail as to what happens in the esophagus. So we often measure esophageal function with a test called manometry. Manometry is a process in which we put a tube that measures pressures down through the nose into the stomach, with many pressure sensors along the way shown here that actually document contraction waves as they go down the esophagus when the patient swallows. So shown here in red is a swallow and the contractions associated with it. You can see that starting from the top, we have a nice progression of contraction going down, which is pushing the food or water down towards the lower esophageal sphincter, which is that ring of muscle or the valve between the esophagus and the stomach. And note how this lower esophageal sphincter relaxes nicely to allow this pressure wave to push the food down into the stomach. Now what happens in scleroderma, particularly with significant involvement of the esophagus, is those contraction waves are markedly diminished. So this is what's called poor motility or absence of motility. Further, what happens is the lower esophageal sphincter, which has you should have a nice high resting pressure, has a pressure that's very low, near zero. So now we have no barrier to prevent acid from coming from the stomach back to the esophagus, and in addition, we don't have the ability to generate pressure waves in the esophagus that can push the acid back or strip away the acid from the esophagus back into the stomach. So it's really a double whammy. We have a poor barrier, and we also have a poor ability to clear any acid that comes and lodges in the esophagus. Now, fortunately, most cases of acid reflux with modern medications are controllable. We always start with lifestyle changes, but in most patients with scleroderma, those by themselves are not enough. Some patients will benefit from elevation of the head end, particularly if they have regurgitation of food at night. And then, of course, what we rely upon mostly are modern acid suppressive drugs, which are the proton pump inhibitors. These are the most potent, most effective ways to suppress acid. Note that they will suppress acid, but they don't necessarily suppress reflux. So regurgitation will continue. The only difference is that it no longer contains injury-causing acids. So some of the consequences of reflux, such as the inflammation, are minimized. So this is fortunately a picture that we don't see anymore. This is severe esophagitis in somebody with scleroderma. With modern medications, you should rarely see this, But if this was to continue, shown here on the X-ray on the right is what we call a stricture. Over time, this acid damage scars the esophagus down, causing a physical obstruction in the lower part of the esophagus.
Wow.
Now, like I said, we can control most cases of acid reflux, but there are some other issues that I think are now becoming increasingly in focus in terms of the consequences of acid reflux. And this is the problem with pulmonary fibrosis or lung scarring or interstitial lung disease. As has been shown, the cause of death in scleroderma has changed dramatically in the last 30 years. It used to be kidney disease, but that has really gone down to less than 10%. On the other hand, lung disease as the cause of death has increased from less than 10% to nearly a third of all cases. And while there are many possible reasons why patients with scleroderma can get lung injury, shown here on the right-hand side, one of them appears to be aspiration or of gastric refluxate, which, in other words, the acid reflux or other kinds of reflux that's come up into the esophagus is then aspirated into the airways, goes down the lungs, where it generates an inflammatory response, ultimately resulting in fibrosis. And this is shown graphically here on the cartoon on the left side, but I want to point your attention to the study that was very provocative, and it came out a few years ago, that looked at patients with pulmonary fibrosis on high-resolution CT scan. This is the group A, and compared that to another group with scleroderma who did not have pulmonary fibrosis. That's group B, and they also had healthy volunteers as a comparison group. So what these investigators did was to look at the incidence and severity of reflux in these three groups. And as you can see here, total reflux was much higher in patients who had pulmonary fibrosis compared to those without fibrosis, which were actually quite similar to healthy volunteers. Acid reflux, which is that part of the reflux that contains acid, was also much higher in patients with pulmonary fibrosis and scleroderma, as well as non-acid reflux. So both acid and non-acid reflux are common in patients with pulmonary fibrosis and scleroderma, and may well be the case that at least some of these patients' pulmonary complications are due to ongoing reflux. That has not been proven yet, but it is a subject that is very, very important for further research. Now, the point has therapeutic or treatment implications as well, because if non-acid reflux is contributing to pulmonary fibrosis, then simply taking care of it with acid-suppressing medications may not help, which is why there is now an interest in non-surgical but anatomical approaches to preventing reflux. So here, shown here on the upper left hand, is a traditional surgery for reflux, the so-called Nissen fundoplication. This is not something that we recommend in most patients with scleroderma because their esophagus does not work and they end up having obstruction. Many of them can't take the risk for major surgery as well. So there are now a variety of less invasive ways to prevent reflux. Shown here is a magnetic bead that's placed around the lower esophageal sphincter area, and that opens and collapses nicely, acts like an artificial valve. And there are some endoscopic methods shown here that actually go in and staple the valve and make it more effective. And many others that I have not shown here are being developed as we speak. So in the future, this may be another option for patients with scleroderma and reflux, particularly those who have significant non-acid reflux, particularly if you're interested in preventing lung complications. Now, going on to the stomach. This is a video that illustrates how the stomach works. I hope that we can get it to work. If not, okay, here it goes. So we should loop through this many times. So what's happening in here is, let's start from the top in just a second here. Food is coming down the esophagus, but the stomach is relaxing in order to let the food be accommodated without causing a rise in pressure, otherwise things would get very uncomfortable. Once it gets into the stomach, it is then pushed down into the distal part of the stomach, where it is ground into very fine powder, and only particles less than 2 millimeters are actually allowed to pass into the intestine. So the stomach is actually a very sophisticated organ, not just capable of storage, but very important in the process of preparing food for further digestion. What happens to the stomach in scleroderma is that it also is affected in terms of the nerves and the muscles, and it shows slow gastric emptying, a condition that we call gastroparesis. This actually occurs in up to 50% of patients. And the major symptoms of this condition are nausea with and without vomiting, bloating, fullness after a meal, and inability to complete a meal. And you can see that what happens in gastroparesis is that the stomach does not relax, as I showed you in the previous cartoon, which means that you get full easily, because as soon as the bolus stomach, you start having a rise in pressure that gives rise to this feeling of fullness. And the pyloric sphincter does not relax, and so food does not empty the stomach to go into the small bowel. Unfortunately, we don't have a lot of good drugs to speed up the stomach, and so gastroparesis remains a significant clinical challenge, unlike acid reflux. The drugs that are available, such as metoclopramide, have significant side effects. Domperidone, which is a drug that is similar to metoclopramide but does not have some of the CNS side effects, is unfortunately not approved in this country, and the FDA has clamped down pretty hard on the use of this drug, so it's not easily available. Erythromycin is an antibiotic that also accelerates the stomach, but it's only effective in the short term and can cause significant side effects in others. We also use some other drugs, such as pyridostigmine, which is a drug used for myasthenia gravis, but these are not very effective. Most of the time in patients with severe gastroparesis, we end up using a variety of anti-nausea. Some of these are shown here, including dronabinol, which is the active component in marijuana. Some of the drugs like ondansetron, the active component in Zofran, is widely used, but they're not very helpful. We use some antidepressants, such as mirtazapine, that can have significant anti-nausea effects. And then we are trying some new drugs experimentally, such as aprepitant, but we are not sure whether they actually work or not. Moving on to the small bowel. The small bowel is the largest, longest part of the GI tract, and its main function is to mix up the food with the enzymes, and thereby promoting the breakdown of food into molecules that can easily be absorbed. So again, this is a video showing how small bowel is also affected in scleroderma. Again, we see the same manifestations, that is poor motility, poor movement. And when you have poor movement in the small bowel, this leads to interference with the absorption process, so that molecules stay in the gut, and these can be osmotically active. They bring in fluid into the gut and can cause diarrhea. Equally importantly, the flushing action of the small bowel is affected, so bacteria find pools of stagnant fluids in which to grow in, leading to a condition called small intestinal bacterial overgrowth, or SIBO. And all of these together can cause bloating, distension, diarrhea, and malabsorption, and in severe cases, actual malnutrition, because the malabsorption is so severe that the nutritional needs are not met. And this occurs in about 10% of the patients. Again, treatment for small bowel dysmotility in scleroderma is limited because we don't have good prokinetics or good agents that can stimulate motility. Again, we try erythromycin, but it only works for the short term. In some patients, we use injections of a drug called octreotide that seems to stimulate the small bowel, and unfortunately, it's an injection that has to be given under the skin several times a day for an indefinite period of time. But in all patients, we look for and aggressively treat the small intestinal bacterial overgrowth with antibiotics. Sometimes these antibiotics have to be given chronically. I have some patients who cycle on and off antibiotics every other month, and that seems to help a significant number of patients. Finally, I want to talk about the large bowel manifestations as they affect the colon and the rectum. On the left side, again, is a video illustrating how the colon works. The colon is a much more passive organ than the small bowel or the stomach. It really only goes into full-blown movement once or twice a day when it has to push this bulk of stool from the right side to the left side. Most of the time when the stool moves to the left side, it sits in the rectum and is stored there until you're ready to have a bowel movement. Now, what happens to the colon in scleroderma is that motility again is affected, so it's unable to push stool across towards the rectum, gets dilated as shown here, and actually forms these large wide-mouth diverticula, which can then cause problems of their own with pooling of fluid and stool. So the treatment for constipation, right now we have two broad categories of treatments. One that use osmotically active agents, which is basically we push molecules that attract water and cause the stools to become watery, most common being the PEG solutions, of which Miralax is an example. Unfortunately, the problem with increasing the water content is that many patients with small bowel disease already have increased water content, and so this may not be a very satisfactory solution. The other approach is to stimulate the colon. Again, we don't have good drugs for this in the U.S. There's a new drug that was introduced in Europe and Canada, and I recommend many of my patients to try it. It's called prucalopride. This is an improved version and in the same class as Zelnorm, which was available in the U.S. several years ago, and many of you may be familiar with that. And then finally, we come to the bottom of the GI tract, where a significant number of patients with scleroderma are also affected. And this is the anal sphincter. The anal sphincter has two components. There's an internal component, which is smooth muscle, like the rest of the gut, and there's an external component, which is made up of skeletal muscle. Most patients with scleroderma will have some atrophy or weakness of the internal anal sphincter. And the internal anal sphincter is very important for maintaining continence of stool. In fact, we see incontinence, fecal incontinence, in about 20 to 40% of patients with scleroderma. Now, if you have a weak sphincter and you have loose stools because of small bowel bacterial overgrowth or small bowel dysmotility, then you can see maintaining continence can be very, very challenging for some of these patients. There are no good drugs for that. There are a bunch of promising devices that are coming out. One of them is a sacral nerve stimulator that requires the implantation of electrodes around the sphincter, and this is then controlled by a pacemaker that's tucked under the skin. And this has promising results in general in patients with fecal incontinence, although the number of patients treated with scleroderma with this device are somewhat limited. There's also bulking therapy that's used. So you inject, for instance, some kind of a polymer. This is an agent called Solesta. Inject this very simply through the skin right around the anal canal and bulk up the sphincter. And this helps, at least in some cases, with mild incontinence. We're also working on a clinical protocol, which we will start next year here at Hopkins, where we are taking the patient's own muscle from their calves by doing a simple biopsy, growing that muscle in test tubes, and then injecting them back into the sphincter. So what I've talked about today is that the gut is the commonest internal organ to be affected by scleroderma. GI manifestations can affect the entire gut with different consequences and symptoms. Treatment options are limited, but most patients should be able to get some relief at least of their symptoms. But as can be seen even with this short, relatively superficial talk, that there are major unanswered questions. In my mind, one of the biggest questions is what causes the GI manifestation? Despite knowing about this for more than 100 years, we still don't know the exact answer. We think that the primary defect is in the enteric neurons, but how these get affected is not known. What we are now comfortable with saying is that fibrosis, scar tissue, is not the major problem, at least in the majority of cases early on. It may become something that's important later in the disease, but in the majority of patients, it's not like the organ is so scarred down that it's beyond hope. The problem seems to be still at a stage where if we could find what it is, it's potentially treatable. And of course, if we don't know what's wrong, we can't develop effective targets for new drugs. But we can hopefully start stimulating or trying to push for agents that improve motility, because as you can see, the fundamental problem in scleroderma is a lack of motility. And again, we just don't have good drugs for motility in general, not just for patients with scleroderma, but in general. Another important question which I alluded to today is, does reflux or GERD truly cause pulmonary disease? And related to that, what are the best non-surgical methods to stress sphincters, whether it's in the esophagus or in the anal canal? I want to just sort of end by showing you research in our lab about trying to discover the fundamental problem in scleroderma. So as you know, collagen is a major player in the pathogenesis of scleroderma, and we are showing that collagen is actually also very important in regulating the health of enteric neurons. So shown here on the left side is a healthy mouse with the neurons shown in green and collagen standing in red. You can see there's very little collagen around the neurons, but in a mouse with diabetes shown on the right, there's massive amounts of collagen that's trapping the neurons, and what we've shown in our lab is that this actually causes death of some of these neurons in our experimental animals. So we may be coming a little closer to finding out what the problem is that affects the GI tract. And I would like to come to a point sometime in the next few years where I don't have to show this slide anymore because I hate showing this slide. My patients expect a lot from us, and we try very hard to treat them, but we really need help in coming up with better targets for treatment and better ways to hit those targets. Thank you very much for your attention.
Jay, that's really terrific. Thank you for such a clear and wide-ranging presentation at the same time. There have been a number of questions, and I'll try and organize them into some groups because I think that might be the most efficient way. A number of the patients are really curious about diet and whether there are, I guess, sort of on one end, are there a set of foods that we should sort of think about avoiding, and that's probably both with relates as it's to reflux, I guess, and potentially to bacterial overgrowth, and then all the way down to sort of a question about, are there some specific, diets that could potentially be, useful or if overdone, potentially dangerous, for some of the treatments. Do you want to comment a little bit on that as an aspect of effectively the therapy for GI disease and scleroderma?
Right. So, in part, the answer to the dietary question depends on what the underlying clinical disorder is. In general, though, if you're talking about gastroparesis or small bowel dysmotility, what we recommend are low residue, low fiber diets, and particularly low fat, low residue diets may be helpful for gastroparesis because fat is a fairly potent nutrient in terms of slowing the stomach down even further. So we want to minimize the amount of residue in the stomach because the stomach is having a hard time getting rid of whatever is coming in. Now, of course, that's not the healthiest of diets that we would otherwise recommend to people because it's actually the opposite. Maybe ask people to take high fiber. Of course, we still, apart from the low fat part. But it's a trade-off in these patients because they just can't handle those kinds of complex foods if their stomachs and intestines are not working properly. In addition, what we recommend for gastroparesis is small meals, small frequent meals, and that's something the patient themselves actually, most patients adapt to because their stomach gives them a signal very early on in the middle of a meal that they can't eat much more. But we'd like, as far as possible, to continue to use the gut for maintaining their nutritional needs. I really I'm very reluctant to put patients on TPN as far as possible because I think that's really got a lot more risk to it. So we try our best to make patients use their gut. In some patients, we may end up using implanted tubes, J-tubes or G-tubes, but generally, if the patient has reached that stage where they have inability to absorb from the gut, then we sometimes have to give up and say, okay, we're going to have to feed you now intravenously. But hopefully that doesn't happen that often.
That's great. I mean, obviously there's sort of a bunch of anecdotal literature on sort of foods that are sort of refluxogenic, mint, chocolate, garlic, in particular, I suppose. I mean, do you have sort of a list that you'd want to help communicate to our audience about things that they might want, foods or food groups or particular things they might want to consider avoiding in particular if reflux is a problem for them?
Well, so there are certain things that are widely associated with worsening reflux. Some people react to coffee. Some people talk about alcoholic beverages, onions, some foods that, chocolates in some patients, will promote reflux. And in most patients who are on PPIs or on these strong acid suppressing drugs, these influences are relatively minor, and the occasional chocolate or coffee can be imbibed without really any significant precipitation of symptoms if the patient is taking these drugs. If you're trying to control your reflux without using these drugs, then of course these measures become much more important. Now, as far as other conditions are concerned, going apart from reflux, so for small bowel dysmotility, particularly those which have bacterial overgrowth, we recommend that patients avoid fermentable or easily fermentable foods, particularly carbohydrates. So some of you may have heard of the FODMAP diets, which people with irritable bowel syndrome are cautioned about. And I think we kind of tell patients the same thing. Try to avoid simple sugars or carbohydrates that bacteria love, because that may just lead to more fermentation in your small bowel, more bloating, more gas, more discomfort.
That's really helpful. Back to some of the pharmaceutical opportunities and I guess, and frankly, and partly challenges with the current agents that are available. Obviously there's some precautions and so forth associated with domperidone, in particular, some of the cardiac potential tox issues. I mean, obviously we're not providing specific medical advice, but how concerned would you be in what should patients be watching for if they're considering domperidone?
Well, first of all, the official position of the FDA is that nobody should be on domperidone without being enrolled in a protocol in which the prescribing physician has an arrangement with the FDA through what's called an IND or investigational new drug. Increasingly, hospitals are enforcing that. Having said that, many patients are still getting their drugs from outside the U.S., online or otherwise, and I think it's really important to keep in mind that the safety of domperidone, while it's been around for a long time, has never really been established comprehensively in this country, which is one of the reasons that the FDA has not approved it. I would very much like patients to check with their physicians, particularly for the need for periodic EKGs, because as you pointed out, Luke, one of the things that we worry about is a prolongation of the QT interval, which is a part of the electrocardiogram that, if prolonged, can predispose the patient to disorders of cardiac rhythm. And there are many drugs that actually do that, including some drugs we talked about today, such as erythromycin. So a lot of these patients, because of the complex medical nature, end up on a variety of different drugs, and if you throw in a drug that nobody is really very familiar with, such as domperidone, you have to be particularly cautious to make sure there are no interactions going on, particularly with respect to the cardiac issues. I hope that answers your question.
I think that's really helpful. Can we go back to this issue about non-acid reflux for a second? Because I do think many scleroderma patients are on PPIs or even a combination of PPIs and H2 blockers, and so they have kind of quote-unquote full pharmacologic acid suppression. But, given that the sphincter itself is probably, not, less than fully functional or non-functional, as you pointed out, they probably have non-acid reflux. And can we spend another minute or two and talk a little bit about sort of the level of data as it relates to pulmonary fibrosis? And do you think patients who have maybe incipient pulmonary fibrosis should then get checked for non-acid reflux, or even if they're on PPIs? Or what's the right way to sort of think through that if you're a patient with disease?
That's a good question. It's a difficult one to answer categorically, Luke. I think the field is in flux. So you have actually two questions folded into one. The first is non-acid reflux harmful? So the cause and effect studies have not yet been done. And to do that, so what we have right now, what I've shown you is an association study, right? So you take patients with fibrosis,
right,
compare them to ones without fibrosis, you have an increased incidence of both acid as well as non-acid reflux. Now, it doesn't tell you that's causing it, it's just saying there's a likelihood that they may be related. And so the definitive study would be to actually stop the acid and non-acid reflux and then see what happens to the course of pulmonary fibrosis. Does it occur at all, or does it slow down? Now, that's relatively easy to do with acid reflux because we have good drugs. It's not that easy to do with non-acid reflux because that would require anatomical reconstruction of the sphincter. By that I mean some kind of surgical or endoscopic means to reconfigure the architecture of the sphincter so it becomes tighter. Now, traditional surgery, even laparoscopic surgery, is difficult to do in these patients, particularly those who have lung disease, because they're at risk for the complications of anesthesia and surgery itself, but also because their esophagus is not working. It's not just the sphincter that's weak, the esophageal body is not working. So if you overdo it, if you make the sphincter too tight, now you're going to have the opposite problem where you're going to have obstruction. In a normal person, that's not a problem because the body can contract, the esophageal body can contract vigorously enough to push things through a tight sphincter. which doesn't happen in scleroderma. So many surgeons have been very reluctant to operate on these patients, which is why I've been pushing for the last year to see whether we can, in fact, explore the use of some of these non-surgical, newer techniques that are done endoscopically, and whether these may be better tolerated by patients with scleroderma or other high-risk patients, and whether, in fact, they may be effective in treating non-acid reflux. Once we establish that, then we have a tool by which to answer your question, which is, will this prevent pulmonary fibrosis? Until we have that tool, I think this question is going to remain relatively sort of out in a gray zone. Your other question is, should everybody be screened? That's a very good question. That's a question that I think most people will say yes. They'll actually say yes to even patients without scleroderma. If you have significant heartburn, you should be screened because you want to look for complications such as Barrett's esophagus. But if you have scleroderma, regardless of whether you have symptoms or not, there is a case to be made for patients to be screened for reflux disease because of these potential complications, some of which are proven and some of which are possible but not definitively proven. So I think it'll vary from person to person, and there is no large-scale study that actually has scientifically addressed this question, but if you would take a survey, most people will say yes. I definitely would say yes, everybody with scleroderma should get a simple screening for reflux, and probably even if they're asymptomatic but they have reflux, should be put on treatment.
That's really helpful. And then, Jay, you mentioned some of the more esoteric, I think maybe futuristic aspects of some of the things you're working on. Maybe in the last couple minutes here, we can just start to paint a vision for where maybe some of the, basically stuff that's still probably deep in the lab might go. And we talked about growing muscle tissue and transplanting that back. As I understand, that's probably more for the anal sphincter. Do you want to talk a little bit about maybe sort of stem cells and basically maybe stem cell injections and trying to basically use stem cells to rebuild sphincters and just some of the other, if you will, I'd say, more futuristic aspects, just to sort of do some speculation here at the end and excite folks about some of the potential.
Right. So the first comment is related to this muscle transplantation. We're actually developing that both for the anal sphincter and for the esophageal sphincter. So potentially it could be a treatment for both fecal incontinence as well as reflux. What we've done, and we published this, we've done in animal experiments, is that you take skeletal muscle, because what we're doing is, what we're proposing is, again, just to summarize quickly, we're proposing is autologous transplant. So your own muscle cells taken from your calf muscle by a simple biopsy. It's actually a very superficial biopsy. And what we do is we take the skeletal muscle from that biopsy, grow it in culture, and there's a company that's actually doing it. It's called Myocyte. It's done under FDA-approved GMP facilities, and then they ship it back, and then we inject this into the sphincter. Now, this has been done in urinary incontinence already in humans in Canada. They're finishing up their phase 3 studies, and we are going to start now for fecal incontinence next year here in humans. And by the end of next year, we hope to finish our studies in animals for reflux, and then start hopefully in patients with reflux. And that's the best way, I think, for really rebuilding the sphincter, because what we see in the sphincters in these patients is a lot of atrophy or weakness or thinning of the muscle fibers. So this actually bulks it up, but not just passively bulks it up, but this is muscle integrating with muscle, so you actually have a truly functional sphincter again. Now, but that begs the question as to what causes the muscle weakness in the first place. And we think it's not the muscle per se that's affected, it's the neurons that are affected. So what we think is happening is that there's the primary defect in scleroderma in the gut, maybe in the nerves, and it's the loss of function of these nerves that causes atrophy and thinning of the muscle. So what we need to find out is what's the defect in the nerves. And I think our study on stem cells is showing on nerve stem cells is showing that the environment in scleroderma in the gut, perhaps related to collagen, is very unhealthy for these nerve stem cells. And the nerve stem cells don't proliferate, don't thrive, and the nerves that do form die. So what we need to do is figure out what is the pathway that we can block that will allow these stem cells and the nerves to regenerate. And so that's a deep down level of inquiry. But in the meantime, Luke, even research that helps us find new motility drugs, even though we don't know what the problem in scleroderma is, but if they can stimulate the gut, that would be a huge breakthrough.
Jay, this has been fantastic, a really fantastic session. I'd really like to thank you very much for the hour you've spent with us. We're all part of the scleroderma community, and it's really great to give our patients access to the expertise that you bring to the Center for Neurogastroenterology at the Johns Hopkins University School of Medicine. So,
thank you very much, Luke, and you all know how to reach us here. We're always happy to see patients or offer advice. This is a challenging disease, and we see some of the most challenging manifestations. We want to work with patients and their advocates to help find a cure.
Thanks again, Jay. And to all of you who are still online, when you do close the webinar window, you can provide helpful information back to the Scleroderma Research Foundation by completing a very short survey. And also, please remember that we do depend on your support to continue our investment in research and in the cure. Please do visit us online at sclerodermaresearch.org. Thanks again for sharing time today. And please remember, all of our webinars are available on our website. Goodbye for now.
Thank you. Please stand by.